Welcome back to the show, folks. Today we have the incredible pleasure of being joined by Dr. Saskia Sivananthan. Saskia, thank you so much for joining us today.
It's my pleasure. Thanks for having me.
Of course. So we always start every episode with a Patreon question. So we have some amazing supporters that are members of the village, and every month they help us bring the show to life. They get the opportunity to ask guests one question, and here's the question that they've asked you. You ready?
Ready to go.
I keep hearing that federal dementia funding has been reduced. As someone looking at this from a big picture perspective, what does this mean for real world support on the ground for families and people living with dementia in the next few years?
Yes. Okay. So the National Dementia Strategy, I think, is what they're referring to, had a commitment of over $75 million that went towards supporting the strategy. I hesitate to say implement it because we can talk a little bit more about what implementation is versus maybe granting to programs and supports. But there was quite a bit of funding that went through, funded over 86 projects as of the last count we looked at, which was December 2025. I think there have been a few more projects that have come out since then. That funding has ended. We got confirmation of that actually at the UN when we asked specifically because Canada hadn't confirmed that information yet. We had presented to the UN CRPD, the Convention on the Rights of People Living with Disability. Canada is a signatory there. And the Canadian delegation then confirmed that the funding has ended, but the strategy has not. And that's because the strategy doesn't have an end date per se. It was released in 2019, but if you go look at the strategy, there's not a end time point, which some strategies do have. So this doesn't have that. And so the way Canada looks at it is, well, we have the strategy. It can continue even if the funding has ended, which is a very interesting approach to take, in my opinion, because if you don't have resourcing to continue the work, then how do you ensure that vision? That being said, there was legislation that said that there would be $4 million available annually that continues indefinitely. There was no end date to that $4 million, but that's it, specifically linked to the dementia strategy. So in answer to the question, yes, funding has ended because the bulk of it did end last year. There's only $4 million that still continues. We're unclear on how that $4 million is currently being used. Also unclear on how the 86 plus projects that were funded, that were pilot projects across the country, mainly programs to support education and awareness raising, how those are being sustained or integrated into the health system.
So I think the confusion, though, Saskia, is if we look at SMART goals, right? If we consider this strategy a goal, like a thing we want to accomplish, SMART goals being specific, measurable, attainable, relevant, and timely. We don't meet that criteria. Like these goals are, if we don't have a time constraint on it, I can just keep kicking the can down the road. So how do we actually get anywhere to solve anything if we say, we'll eventually solve it? You're never going to do it if you don't set a timeline. It needs to be done by blah, blah, blah day.
Yeah. And not just a timeline, an explicit, measurable, achievable goal, right? You can set a goal that's not achievable, and you can set a goal that doesn't have a timeline or resourcing to support it. And that was it. That was entirely the purpose of our report, the Mind the Gap report, right? And the strategy is a strategy. And that was why I said earlier, right? There's a difference between a strategy, which can kind of set out the broader vision, and then the actual implementation. Usually it would be called an implementation plan or an action plan that is phased, that has measurable goals and data to support how you're measuring and achieving those things. And the whole point with the dementia strategy is there are 5 pillars, I believe, with, broad goals, things like we want to increase the quality of life for people living with dementia. It's one care pillar. Phenomenal. We all want to increase the quality of life. We know that needs to be done. How is that being done? And that was where the Mind the Gap report looked at other countries who had implementation plans, action plans that were very specific as well about who's doing what. Because we are a federated system, this is another gray area, right? The federal government can't actually step in and tell provincial governments how to run their health system. And the health system delivery happens at the provincial level. Those decisions around how funding is allocated, what happens at the provincial level. But there are mechanisms that the federal government can leverage in terms, well, it holds the purse strings, it holds the dollars. And so it could say, we will support these resourcing potentially through bilateral agreements to achieve these goals. Here's the outcomes, here's the data measures. The other way, and this is where there's learnings from, cancer or stroke, mental health as other examples, where they convene. It's either an FPT, a federal provincial territorial table, or leads from all the different provinces and territories who agree on, here's the goal we want to achieve over the next year to 2 years. Here's how each province is going to work to achieve that. And here's the federal government's role in helping convene and provide the leadership to do that. And that is missing entirely for dementia. There is a ministerial advisory board. It is advisory only. I sat on that board, so I know what its role is. It doesn't achieve that purpose or goal either.
Why 4 million? Because 4 million seems insufficient for actually solving, frankly, anything. I mean, by 2030, we're supposed to be, what, 1 million people living with dementia in Canada? So $4 a person, what are you going to accomplish with that? We're giving, whatever, $23 billion to Ukraine to support all that initiative with the war over there. But we're giving a fraction of that to the folks domestically that are living with dementia and their caregivers. That doesn't seem to adequately address the problem.
Yes, is the short answer. I don't know where the 4 million came from or how they landed on a $4 million budget. Also unclear about what you're doing with the 4 million, right? Are we going to continue to grant fund pilot projects across the country and hope that those projects are sustainable on their own? It's unclear. And I don't know. I would say that what we do need to do is have very, very strong advocacy. We need people living with dementia, caregivers, families who are outraged and dealing with this system to say this is completely insufficient. This is not what we expect of our governments. This is not what we expect of our elected officials. We need funding that supports care coordination. We need funding that adequately supports better research so that we can have these kinds of programs that are sustainable and integrated into the health system. And
Is that a federal challenge then? Like, would that be a conversation with your MP because we have this federal national strategy, or would that be with your MLA because this is a provincially run support being seniors in health?
it's actually both. So you would talk to your member of parliament, right, who sits at the federal level. They would advocate for dementia to be a priority, a health priority, and to advocate for funding, and for that funding to be very specifically defined in terms of how it's being implemented and how it's being rolled out at the federal level. But then you also want to have a conversation with your MPP, your provincial member of parliament, because almost every province has a dementia strategy of some sort. And it's the same problem. They also don't adequately allocate resourcing or have very clear goals for what they're going to achieve. If you look at any of the dementia strategies at the provincial levels, it's the same sort of broad goals around quality of life, wanting to support care. How? Explicitly, how is that achieved? And we know that we've done that for other conditions. So it is conceivable to do it for dementia. Why are we not doing that?
Where's the puck lie? Well, who lands with that? Like, if we have to say it lands with this person, this is who needs to step forward and make a change, because everyone keep pointing fingers. Like, it's the old Spider-Man meme, right? Everyone's pointing every single direction. But like, who does this actually land? Is this an Alzheimer's Society of Canada needs to step up and say, hey, this is our role. We are supposed to be the emissary of that. Is this a Mark Carney thing? Where is this a Danielle Smith here in Alberta as the premier? Like, who's actually accountable for this? We had a tribute, like, this is who needs to start this direction.
Well, I think it's because it lies so many different players that it's difficult. It lies squarely with the Minister of Health in both cases. The Minister of Health at the federal level owns the dementia strategy. So the National Dementia Strategy is part of her portfolio. The Public Health Agency of Canada and Health Canada report to her. So they would be responsible for implementing that strategy based on her direction. The same thing for the Canadian Institutes for Health Information, CIHI, and the Canadian Institutes for Health Research, CIHR. CIHR is the research arm of the federal government, so they would be implementing the research aspects. And CIHI is the data collection arm. They would provide the indicators that would support whether we're achieving those goals, right? But the responsibility sits with the federal Minister of Health. Your members of parliament can intervene or can ask for that to happen with the Minister of Health, raise it as a priority through committees that they sit on, through Q&A periods. They have many opportunities to do that. They would be able to identify what that looks like. So that's the federal level engagement. That's for the federal strategy, right? Just the national dementia strategy. So getting the funding for it and having that flow through to the provincial governments. But the provinces and territories themselves also allocate funding to this, right? And we just recently actually took a deep dive into Ontario because we are looking at how Ontario is structured, as well as Alberta and New Brunswick. These are some of the provinces that have identified that dementia is a priority and that they want to move it forward. And they allocate their own money to these, either to these conditions or to a framework that would support those conditions. And they can then decide, again, we want to allocate X amount of dollars to dementia to support care coordination. And I stress, you do not want just programmatic funding. I think this has been another big issue with the way we fund things for dementia versus the way we fund things for other health conditions. With dementia, we treat it like a one-time thing. So we'll say, we're announcing $30 million that's going to go towards supporting better emotion-based care in long-term care for people living with dementia. Or we're going to fund $10 million that goes towards dementia-friendly communities. But that's programmatic funding. Once that funding ends, or if the political party changes, or it is no longer a priority, you're done. What you need is funding that goes into the health envelope. It is base funding that is built into the Ministry of Health envelope, funding envelope. That doesn't exist for dementia. So this is the other piece that needs to be really thought through legislatively. How does that happen so that dementia has continuous funding? It doesn't just get cut whenever there's a deficit or whenever program funding ends.
This reminds me of a conversation we had on the show here with Dr. Sharon Anderson, and she was talking about we can't build our way out of this problem. Instead, we need to support and fund the day-to-day caring. So, and one of the examples she gave was, people that take a leave from work to be a full-time caregiver, they need compensation so they can continue to be supported that way. Wouldn't it make sense to start driving that sort of funding as a manner of providing direction rather than we're going to create this program? Like one of the $4.7 million programs that's being funded in 2026, it was announced a month or two ago, was an art gallery of Hamilton providing special hours for people with limited dementia to go in and get access to this art, or the National Ballet School of Canada to be able to make a video about how people with dementia are doing ballet. So wouldn't it make more sense then from a policy perspective to make things that are more broad and accessible rather than specific to a very niche, granular group?
Yeah, I mean, I work with Sharon and I follow her work as well. And I think there's two aspects to what you're asking me. The first is caregivers who we know they're the backbone of support for people living with dementia. And in fact, they provide probably 95% of care in all forms, coordination, navigation, day-to-day care, and it's all unpaid. A lot of it falls on women. So we can talk about that side of it. But I think what she's talking about specifically is funding supports for caregivers, not just programmatic. She's talking about economic supports. So just like we have disability supports, caregiving supports that way that are built into how we fund and finance for caregivers. So I agree. That's a sustained, integrated, ongoing approach to being able to support caregivers. But what I'm also saying is, like those, you just mentioned niche programs, and they're good programs, but they're
I agree.
for a limited population, right?
Hmm.
And one of the things we identified in the Mind the Gap report, we looked at some of where the funding went for the National Dementia Strategy. And this is from the Public Health Agency's own accountability report. They did a process review of where that funding went. And of the $20 million that was spent, not just, it's a big chunk, it reached less than 1% of people living with dementia. So we know this is not an effective way to do things. You cannot just grant fund and fund these small programs. You do need integrated care. That is why part of the work that we're doing through Brainwell has been focused on get a dementia unit in place at the provincial level that is responsible for care coordination. And that's built on looking at how we've done things for other conditions, for cancer, stroke, renal disease, palliative care, mental health. These are other major conditions that cut across just health, right? They touch housing, they touch social determinants of health, transportation. What they started to do more effectively was once they had folks who were responsible at the provincial level for understanding all of these gaps and connecting the dots and integrating and sustaining those programs, you then started seeing, oh, here's where there's more gaps where we might need to actually build a program or a certain type of support. But here's where, when we measure outcomes, we're not hitting the mark. So for cancer, for example, one of the outcomes was wait times for access to therapy. Very explicit. It's very specific. Let's say I'm making this up. It's like no more than 2 weeks from point of diagnosis to getting access to treatment. That's measurable, it's specific, and accountability is tied to that. If the organizations are not achieving that time frame, then they have someone come in and do a review to understand why that's not happening. They have funding tied to meeting those outcomes. We just don't do that for dementia. And this is the analogy that I use. It's when you travel, it's stressful, right? It can be, depending on where you're traveling. And you have these routes to, let's say you're traveling from Toronto to London. So you know that there's a flight route to take, and there are lots of those routes all over the world. Those are like the pathways that we keep talking about for dementia care. Great. You need those because you need to know where you're going. But then you have all these programs and people who help deliver those pathways. That's like your planes, right? The plane takes you from Toronto to London. That's like a program that'll take you from A to B. But now can you imagine flying like that without having any air traffic controllers? Like, what would happen if you didn't have air traffic controllers at airports?
It'd be chaos.
Total chaos. You'd have flights crashing mid-flight, which that's what's happening to caregivers. You'd have massive pileups on the runway because no one knows when they're supposed to be taking off and when they're supposed to be coming. Guess what's happening with our programs and services right now? We have massive wait times. You'd have planes circling over airports because they don't know when they're supposed to be landing. They'll run out of fuel at some point. That's how care for dementia is currently being managed. We don't have the coordination and we don't have the air traffic controllers who have the data and who have the outcomes and can see the system to know how this all needs to fit together.
What's interesting is I look at this from an Indigenous lens, and everyone tries to navigate it, and everyone seems to, you do this bit, I do this bit, let's try and coordinate, and nobody's really coordinating because everyone's trying to coordinate it. I equate it in my mind a lot to Jordan's principle. Are you familiar with this?
No, I'm not. Tell me more.
Okay, so what happened is there was a First Nations boy named Jordan, and he had some severe health situation, and there was a battle between the provincial government, I can't remember what province, provincial government and NIHB. NIHB, so non-shareable health benefits, said that the provincial government had to cover his health first, and provincial government said no, he's status First Nation, so NIHB has to take it. So the two were combating, saying no, you have to deal with it, you have to deal with it, you have to deal with it. And ultimately Jordan ended up dying because he couldn't get the care that he needed. So this principle called Jordan's principle was created that says, doesn't matter what's the dynamic between these two. This is the process of how we deal with it. And on the back end, you guys can fight it out. It doesn't matter. The child or the First Nations person, isn't stuck in this battle. And that's why children under the age of 2, for example, if they're born to a status person, they have NIHB benefits, even if they are not inherently eligible for it, because they don't want to get stuck in this position of back and forth. And I think through this process, it's a very similar pathway to dementia, where everyone seems to be pointing at each other instead of saying, you know what, let's put this person with dementia first and then figure out behind the scenes.
Correct. And this is why I'm saying it needs provincial accountability and it needs federal accountability and leadership. Right now, the way things are done is we put the accountability on the programs that are being funded and the charities or the organizations that are delivering it. And they do have some accountability because they are delivering, but that coordination has to sit at the provincial level. You cannot have someone else trying to do that. They can't. And they also can't then enforce if that accountability is not being met, right? If the outcomes are not being met. And that's what we do well. We've done well for stroke and cancer and are starting to do for mental health. I'm not saying they're perfect by any means. I mean, I've had close family members who've gone through all of those journeys, but they are drastically different in terms of access to care and coordination than what we currently do for someone with dementia.
It's so concerning, especially with the fact that it's one of the leading causes of, death, and so many people are getting
Disability.
it that
Yeah.
we're not appropriately figured out how we navigate it. It's super concerning.
This is also the number one priority. Anytime we have convened people living with dementia, and not we, by we, I don't mean brainwash, I mean any organization that has asked people who are dealing with this what they need, the number one issue is system fragmentation. They want to be able to navigate the system and have a clear path through it instead of having to figure it out. I mean, I'll give you an example. I spoke to someone just yesterday whose mom had early signs of dementia. She went to her GP multiple times with her mom, and the GP never diagnosed her, also never recommended any follow up, didn't make any referrals. And this took years. It was 3 years before she was able to finally get that diagnosis. And that was after begging, after it had gotten to the point of crisis. And she finally had to take her mom to the ER. And are we surprised? Because if you actually look at alternate levels of care, these are beds that are sort of in acute settings, like in the hospital, where the person might not need acute care, but also cannot be discharged back to the community. 50% or more of the people in those beds are people who have some form of cognitive impairment or dementia. And that's because they have nowhere else to go. And families and care partners have nowhere else to go. That is why they are coming to the acute setting, even though it's probably the worst possible avenue for someone living with dementia to get care.
We've heard on the show instances of people and their loved ones being in these hospital or acute care settings, and one person said they basically lost themselves in there. They thought that they were being, kidnapped, and
Yeah,
we've had these kind of stories, and
of course.
it's tremendously traumatic to
Dramatic.
these
Yes.
folks, right?
There's no other way to put it. I mean, and that's because acute care is not set up or designed to provide that care, right? It's meant to be you have an acute issue that gets dealt with in a very focused way, and then the person gets discharged. Like you get woken up every hour to take for someone to come and take all your vitals. Imagine that if you have dementia and the lights are on all the time. There's lots of noise, there's beeping, there's codes being called. Like that's traumatic even if you don't have cognitive impairment and you're trying to recover. Now try spending months in a hallway getting that kind of care.
Yeah, it's this whole situation, the whole system. I mean, we can have the best objectives, but if we're not actually moving the needle forward, I struggle with how effective are we actually being. If we're not seeing like this is what we're doing, it's hard.
Yeah. Well, I mean, look, we can be proactive about it. We've talked about that. Or we can be reactive, which is what we're currently doing. But at some point, reactive is going to fall apart. And we are definitely seeing that in every health system across every province right now. there is not a single health province with a health system that is not struggling with ER wait times, ALC beds, access to primary care, access to long-term care. There's not one. And Canada has now entered the age of the super aged, right? Because we have a higher percentage of people who are over the age of 65, 20% or more are now over the age of 65. And that is when the needs increase. That doesn't mean every person over the age of 65 is going to need this kind of support. But if we can be more proactive and preventative, then we get to the point where they can age well, hopefully, and age with more dignity in the location that they want to age in.
Mm-hmm. Well, Saskia, we got right into the conversation. Normally, I do an introduction earlier on, but let's do that now since we got into a really interesting conversation. All right. So, Dr. Saskia Sivananthan is an internationally recognized strategy and policy advisor on dementia care, is the co-founder and CEO of the Brainwell Institute, which is a nonprofit dementia policy think tank. She's also an affiliate professor at McGill University. She was the former chief research and KTE officer at the Alzheimer's Society Canada, where she oversaw a tripling of funding for dementia research and created multiple platforms for people living with dementia to engage in research, advocate, and co-design programming for their needs. In 2020, she was appointed by the Federal Minister of Health to the Ministerial Advisory Board on Dementia. Previously, Dr. Sivananthan served as a senior strategy and policy advisor. Previously, Dr. Sivananthan served as a senior strategy and policy advisor consulting for the World Health Organization on its overall global dementia strategy. Dr. Sivananthan co-drafted the WHO's Global Action Plan on the public health response to dementia, which was unanimously adopted at the 170th World Health Assembly by all 194 member states. This plan served as the template for Canada's national dementia strategy. It identified key priorities and established international goals to fight stigma and advance dementia care. So, obviously, based on that, you have a clear knowledge, right, of what's happened domestically and as well as abroad. So how are we comparing from our plan to other nations?
That was one of the questions we had last year, actually. And we published a report called Mind the Gap. And what we did was we took a look at all other countries that have dementia strategies, but were also federated countries. What that means is that you have a federal government and you have provinces or regions that are independent in how they might implement. So they have to work almost as a coalition, really. And when we narrowed that down, we came to 11 countries. Canada ranks 7th against all of the rest of its peers in terms of implementing its dementia strategy. Now it's kind of like,
Sorry, how are we qualifying those 11? Is it just on it's a federated region, or was there population and economic status and these side of comparative
yeah,
metrics?
no, great question. So they needed to have an active dementia strategy. They needed to have started implementing it. They needed to be a federated country. Their economically needed to be comparable to Canada, so that we're kind of comparing apples to apples, oranges to oranges as closely as we could. Those were the main conditions. And then we started looking specifically at their strategies and whether they had identified goals. Were they clear about what their goals were? Did they have roles and responsibilities outlined? Did they have resourcing allocated, not just financial, but human resourcing allocated to it? Are there timelines around how and when they're going to achieve all of these pieces? So those were sort of we call them the 6 ingredients of success for whether that strategy was really being implemented or moving forward. The last one was, do they have monitoring and transparent reporting? So when we looked at those, like I said, Canada ranks 7th, and the countries that were really doing well are countries like Denmark, Germany, Australia, and Scotland, and Austria. And in the report, you'll see sort of more details around what it is. But what those countries tended to do quite well was they were much more explicit about what they were going to achieve and how, right? We talked about that right at the beginning of the podcast. Denmark, for example, had similar goals to Canada where they wanted to improve quality of life, let's say, for people living with dementia. But where Canada set that as the goal, but didn't have anything further, Denmark went further and specified what their goal was. They said they wanted to increase timely and accurate diagnosis, and they set a target that 80% of people living with dementia must have a specific diagnosis by 2025. That was their target. And then they made sure that they have the data to measure if memory clinics and community-based services were achieving that target. So those are some of the examples about like how we were doing. So generally, Canada wasn't doing poorly, but we're certainly not leading. We're kind of middle to the end of the pack, if anything.
So I've read that Canada, it's a supporting participant globally, but we don't lead and we don't fund any Alzheimer's Disease International initiatives or goals. Does this put us behind the eight ball compared to these other regions and nations with respect to innovation and proactive support?
Well, I mean, I don't know how much other regions and nations are funding Alzheimer's Disease International (ADI). That's the international umbrella. I do know Canada does fund some projects for the WHO dementia unit. Particularly, I think they focused on risk reduction and dementia-friendly communities. But when it comes to innovative approaches to care, yes, we are behind. We tend to look at other countries. We look at Denmark, Netherlands, right? I'm sure you've discussed these on your podcast before. Talked about the dementia village, or we've talked about intergenerational care approaches. These are just not things that Canada is necessarily supporting. We sometimes will create the pilots, but we're a land of pilots. We'll create the pilot. We'll say, oh, that looks really great. You have great evaluation outcomes. And then that's it. It doesn't get scaled. We don't integrate it. We don't take it to the system or policy level where more people can actually access and use it. And that I think is our biggest failure.
How did you get into this space? Like what led you down to being a policy expert and think tank for dementia? What led you down this road?
Well, I actually had always been interested in the brain. That it was a fascinating organ for me. And so I started my career in neuroscience, very bench clinical kind of research. But when I was in Montreal at the time when I was doing my grad studies, and my neighbor had early cognitive impairment, and he lived alone. And was his friend, and basically now in hindsight, I was his proxy caregiver. I didn't know it at the time, but that was what I was doing. I pick up his groceries, make sure he was getting his prescriptions, visit him when he was in the hospital, and try to make sure he was on top of all his conditions. And I also volunteered at the memory clinic when I was in Montreal. And I could see really firsthand that while people could come in and get the diagnosis, where they were really struggling is what to do next. Like they just didn't know where to go next, and they didn't have the supports for where to go next. And I realized that what I was doing at the time was really more around drug development, therapeutic options that were maybe 10, 20, 30 years out, if it even came to market. And I'm an impatient person. That was that was not gonna I couldn't wait that long. I wanted to have a more immediate impact. And so I shifted gears and went back and started learning more about systems, health systems and policy. And that's really how I got into it. I've subsequently had many people in my family and friends who lived with dementia and really struggled with the health system. And this was where I decided that I would work and do work wherever I needed to and however I needed to make that kind of impact. And there was never going to be a clear road to do that. Academia couldn't achieve that. Corporate alone could never achieve that. Industry alone or government alone couldn't do it. You needed to intersect across those to be able to pull all of those threads together. So that's how I ended up here.
How did your role with the Alzheimer's Society as the knowledge officer, how did that um, impact your trajectory and your kind of knowledge of how we exist these systems?
in a very profound way. Um, a lot of my work before that had been at the, I joke, it's like the 10,000 foot view, right? You're looking at a broad health system and you're looking at it from populations, hundreds of thousands of people who are dealing with the system. At the Alzheimer's Society, I would take calls individually from people who were dealing one-on-one with trying to interact with that system, access supports, access care. And that really shifted my perspective because it helped me see how important how you knew you were making an impact at the policy level is when the day-to-day life of the person shifted in terms of how they could access services or how they could navigate through the system. And with the Alzheimer's societies, the societies as large deliver that programming, but they don't necessarily have the space or the bandwidth to link how that programming needs to get integrated to the system. Most of the Alzheimer's societies sit outside of the health system, right? They're providing navigational support, caregiver support, day programming. Those are not integrated or in the health system. And so where people were struggling was A, how to get into the health system, and then how to access these services while still trying to figure out where to go next in the health system. And that was why we established the Brainwell Institute. So Alexandra Waite and I, she's also a researcher, but also had lived through that experience of someone living with dementia. We were frustrated because we have been to so many conferences, and Andy, you've probably been there. There's conferences, roundtables, podcasts, so many. And it was over and over again. It was, you need care navigation. We want to know what to go to next, where and how. And we knew how to do that, but it just was not being done for dementia. So we established the Brainwell Institute with that specific objective. It's a 5-year plan. And over the next 5 years, our objective is to get care coordination, the infrastructure and the pathways to occur in at least 3 provinces along with federal leadership. And after that's done, the Brainwell Institute has achieved its mission and we can wind it down. That is how we've set it up to be able to achieve it. We don't benefit from it. We will not run any of those pieces. That needs to sit at the provincial and the federal levels.
Do you see a similar belief from all political parties of saying, "Hey, we see that this needs to be addressed," or is this kind of turning into a partisan issue? We had on an earlier episode, we had the Governor Martin Schreiber from Wisconsin, retired, and he was talking about that it should be a partisan issue or it should be a bipartisan issue, but and ultimately ended up turning into an entirely partisan issue between the states and the Democrats and Republicans. And so, how are we looking at it here?
I don't have a pulse on the U.S. Approach to it, but I will say that in Canada, it is a bipartisan issue. It cuts across every party, whether you're talking to Green, NDP, Liberal, Conservative, every party leader and platform has acknowledged older adults and dementia is a priority. I think what we haven't had is very strong, clear messaging around what does that mean? If you are making it a priority, what do you need to do next? How do you achieve the main goals? What is that goal for dementia? And what we've now started doing is convening task forces at the provincial level where we're bringing all of these organizations together. I mean, if you think about dementia, you have everything from home and community care, long-term care, community-based charities, acute care hospitals, all providing care to people living with dementia. And dementia is not just Alzheimer's disease, right? We're talking Parkinson's-related dementia, Huntington's-related, Down syndrome-related dementia. They're not talking to each other, and they're not aligned on the messaging. But I think through the task force, what we are starting to do is see that alignment. We've spoken to, I would say, over 50 to 100 different participants, organizational decision makers who've all agreed that care coordination and navigation is the number one issue that they also struggle with, and that they would be supportive of that kind of infrastructure happening at the provincial level.
So we know that, using evidence when we're trying to care is important, right? Rather than just some arbitrary thing that's contrived. So we need more evidence, right? We're trying to gain more knowledge, more understanding of the specificity of what people are going through. Do you think that we have enough evidence, or do we still need more understanding in dementia, maybe in specific domains?
I would argue that we have enough evidence to justify that we know what care coordination needs to look like and how to do that, and care integration. I think we have the evidence there. There's definitely other areas where we don't. But if we're talking about the number one issue that people living with dementia identify and that organizations are identifying, we have the evidence. The problem with the evidence is, as a researcher, I feel I can say this, is that most researchers are not very good at articulating how you use their evidence and how do you implement that evidence, and to make it very practical in how that can be implemented. And that's knowledge mobilization and knowledge translation, right? And you've probably heard it's a 17-year gap between the generation of evidence and knowledge and then its implementation. And that's part of what we're trying to bridge with Brainwell, is we have the evidence. In fact, when you looked at the Mind the Gap report and any of the other publications we have, that's not new. That is taking existing evidence and pulling it together in a big picture for how that can then be a roadmap for next steps for implementing.
It makes me think about the landmark study too from the Alzheimer's Society. In practice, it makes sense, right? It's trying to give actionable data that aligns with, the dementia strategy that says we need to support folks living with dementia that are Indigenous. But it kind of lacks teeth, really, because it says we have these problems of saying that Indigenous folk are significantly more likely than general populace to end up with dementia. But I mean, the national strategy doesn't really connect to the nations. I've talked to dozens of health leaders nations, and they haven't oftentimes even seen the landmark study. They're like, yeah, we know it, but we've never seen it. No one's ever talked to us, which is the antithesis of what the national strategy says. And they're like, we have no data. No one's ever came to say, this is what you need to know. Nope, no one talks to them about it. So we can have this data in practice that's trying to solve a thing. But the people on the ground that are actually going through it in arguably the worst demographic right now don't have it, don't know how to deal with it. They are not able to actually access the data for their specific nation or region to make informed decisions. So they're kind of left scrambling and holding the bag.
Yeah, no, I agree. I mean, the landmark studies, both of them were pieces that I led when I was at the Alzheimer's Society, and we led them because we realized that we were having conversations, kind of in a vacuum. We're saying dementia is a priority, dementia is a problem, people are struggling, but we didn't actually have anything to back it up fully, and that was where the thinking around the first landmark study came. The second landmark study came because, actually, back to your original question about how working at the Alzheimer's Society affected me. When I was working there, I realized that we were seeing people who were of Indigenous background, people from other diverse communities, people who spoke other languages, who were struggling even more to access the system. And we didn't really understand. We didn't have any good data around what that looked like. Who were these people? What did that look like? What was that journey looking like for them? So that was part of what the second study was, to try and bring a little definition to it. Yes, I absolutely agree. The next step to that now should be, okay, how do we empower you to get your own data and to use that to make the kinds of informed decisions or informed advocacy that you might you might need if you are Indigenous or if you are from whatever other community that LGBTQ plus community also struggles. And so I think there's generating the data and evidence. And like I said, those are areas where there does need to be more research. There needs to be more data. But if we needed data on, do you need care coordination and what does that look like for dementia? We have it in spades. We now need to really get to very practical implementation. What does that mean from a legislative perspective? Like, what legislation needs to be there for that care coordination to happen? Who is responsible for it? What's the governance structure? What's the roles and responsibilities? What's the budget for that? Who reports into who so that that pathway gets implemented? What's the protocol for that? What national data do you need to have to be able to support those measures?
And I think from a direct research perspective, I think that Canada is, at least whether it's Sky High or wherever it's being driven from, I think that they are putting research money into
Hmm.
specifically supporting Indigenous understanding. I mean, Dr. Jennifer Walker and Dr. Pamela Roach are doing amazing work in the space, and they got there in their labs got a
Big grant. Yeah.
significant multi-million-dollar a grant to support and understand that in some of these Indigenous communities. I know Dr. Roach is specifically working with the Métis community um, here, so I think it's good seeing at least that, so we're getting a better understanding of what is this unique demographic need that maybe the system isn't ready to support right now.
Hmm.
Hmm. So I also, Saskia, read that Canada was the last G7 nation to release the dementia or national dementia strategy. Why? What has led to us being far behind? Because it seems that everything we talk about is Canada is trying to catch up. Canada's number 7 out of 11. Canada doesn't have these implementation plan. Is there a epistemological problem that we're having here that's causing us to be in this position?
I kind of reflect on our current economic status, and it's been interesting, right? We can go down a whole rabbit hole around what that looks like in terms of our relationship with previous or current allies. But what was interesting about hearing Mark Carney's speech, where he talked about the middle powers having to come to the table or be eaten, um, I think when you think about healthcare and how we are approaching our populations, it's the same thing. I think you can continue to wait for others to innovate and then maybe think about how you can bring it in and support it. Or you can really focus, take a combined approach, come to the table and develop that plan. I think the federated structure makes it sometimes difficult because where does federal leadership end and provincial leadership come in to really move things along? But again, I'm very optimistic because I've seen it done for other major conditions. It's completely feasible to do. We do need to organize ourselves and be very clear about that goal and not keep kicking the can down the road to say, well, it's not the time right now, or maybe it's later. For why Canada was the last G7 to adopt a national dementia strategy, I don't know the answer to that. There's always going to be other political issues. And I get asked this question a lot. Like right now, we're focused on dementia and wanting that infrastructure, that coordination in place. And often people will say, well, is now the right time? Look at all the economic turmoil and the issues. But when is there going to be a right time? You have an older adult population that is rapidly growing. You have caregivers who are burning out. You have a health system that is completely stretched. There's not going to be a better time ever. So either we do something now or you just keep hoping and waiting until you get to the point where it's so broken that you're forced to have to rebuild from scratch, potentially.
Is there potentially an avenue, Saskia, where um, governments, not just Canada, but governments more broad, let's look at those 11 nations, are really hoping that, a silver bullet will come around and we found a cure. This is great. So we don't want to invest too much or go too far because essentially it'll be a sunk cost if we can cure, say, Alzheimer's, the largest prevalence of this. is there a piece of that in there?
Could you name a silver bullet for any other condition that exists?
I mean, if you talking about a cancer drug, right? If there's a pill you can consume that will solve cancer, then that will make the Cross Cancer and these other organizations essentially obsolete. They will make all the money that we put in that space not worth it. So I would, my fear, and I hope that I'm wrong, but be that, we don't want to go too far down the road because we're seeing all these advances in research with like this thing can reverse amyloid buildup and these kind of things. And so we see that. Is that a compounding factor to we don't want to go too far in because we see these medical interventions that have potential, whether or not they work or not, I don't know, but they have potential that we don't want to go too far down the policy support piece because we hope that this is going to be the savior to this situation.
No, because there is no condition that has a silver bullet. Cancer has received 50, sometimes 80 times more funding for research and treatment optionalities. And there is still no silver bullet because it is a complex condition. Are there therapeutic options to reduce mortality? Yes. To increase the quality of life of the person and how long they might be living? Yes. But we do not have a silver bullet. You're not ever going to get to that silver bullet. And I think Alzheimer's is equally complex, and it's received less funding, had many clinical trial failures because it is such a complex condition. And there are going to be treatment and therapeutic options, and I want those because I think we need those. And you need better ways to screen. You need better ways to diagnose. There are now blood-based biomarkers that can make their way and help us to be able to diagnose earlier and more accurately. So there are all of those things that are needed, but we have to take all of those facets and still consider that even with those therapeutic options, you're still going to have people who need care, who need support, who want to age at home, who want access to rehabilitation so that they can live better with the condition that they have, which is what we do well with other types of conditions. But with dementia, we're so fatalistic. We're just like, oh, they're old. It's a death sentence. Why bother? Like, I'm being very blunt, but that is very much um, underlying how we think about people who are living with dementia. And this is why we don't provide rehabilitative supports, which we could and should for anyone in terms of physical therapy, occupational therapy, speech therapy. These are things that can help the person retain their ability or find other avenues to be able to continue what is purposeful lives. We don't do any of those things for people. We don't help them access preventative risk reduction lifestyle changes and supports, which again can be hugely beneficial. We don't support caregivers with the kinds of things that could educate them early about what to expect, how to navigate through crisis, giving them the financial supports that would enable them to continue to provide that care. Those are all fixable. Those are all things we already have options for. We need policy and funding to support them, to get them into place. And no therapeutic is going to be able to mitigate that.
Especially with the different types of dementia all being different. You can maybe address one, but frontotemporal, Lewy bodies, Alzheimer's, uh, all the assortment of the
And
couple
there are over 100
childhood.
different
Those,
kinds.
oh, it'll be complicated. Did the Brainwell Institute come up with a number of how much realistically it would cost to implement all of these objectives and plans for what needs to happen? Was there ever an economic number that says it will be this much money?
We're working on that. The economic model is going to depend on the health system. And so we're looking to build an economic model for each health system in each province because each one is so different. And a realistic economic model and then a best case economic model. But yes, we will have a recommendation around that, and it'll be tied explicitly to care coordination infrastructure. And that won't, you know, also want to be very realistic. It's not going to resolve all the issues all at once, but it will start being able to better understand what exists and how much of a gap there is and where the integrations need to happen. If you even look at how provinces currently fund, the Ministry of Health funds some things for dementia. Ministry of Seniors or Long-Term Care will fund some things for dementia. Ministry of Housing funds some things. Ministry of Transportation. Do you think all those ministries talk to each other and know where they're duplicating or how those programs are working or how it's actually the same population accessing all of them? But they kind of break them out into separate subpopulations, and that's not how this works.
So would you need a overseeing national coordinating body then that tracks rates, prevalence, outcomes, manages targets, I don't say tracks people, but kind of like gets people across the spectrum,
Yeah,
understands what they all are needing.
exactly. What they're needing, how they're accessing the systems, which programs are they accessing, which ones are hitting the outcomes that have been agreed to at the provincial level, um, and then holding accountability to achieving those. That was that was what cancer did, right? That was what stroke did. They said, if we take stroke as an example, as we talk quite a bit about cancer, they focused on acute stroke specifically because they had a new therapeutic that had come in, but they also knew accessing that therapeutic required a specific window of time. We needed specific infrastructure for it to be able to achieve that. And from there was how they started managing stroke provincially. Almost every province has a stroke network or a sort of formal infrastructure that tracks how people are, who's developing stroke, who's dying from stroke, how quickly they're accessing therapies, are they getting rehab? So that if you don't measure it, how do you know what you're achieving?
I read somewhere, I think it was something you posted, that it's typically 2 years from uh, the time to actually get diagnosed, from when you start seeing these issues with, time to see a doctor, neurologist, testing, all this kind of stuff. Is there a decision to decrease that time so that we can, even if we haven't necessarily clinically diagnosed, we can give them the supports earlier on in advance when the diagnosis takes what it takes, testing. But giving people access to these supports, if we start seeing some of these behavioral changes or symptoms occurring that can, decrease or I guess increase the time in which they're living with this thing so that they can decrease the decline.
Yes, yeah. So you're right. The average, this is national average, so it varies, of course, based on where you live and what access you have. But on average, it's taking about 2 years from the time someone starts to try and access that diagnosis to when they actually get the diagnosis of dementia. And even when they do, they're not always getting a specific clinical diagnosis. So they're being told they have dementia, but they're not necessarily being told what kind of dementia, what the progression will look like, what to expect. And on average, people live 8 to 10 years with dementia. If you're looking at Alzheimer's in particular as the most common form of dementia. There is that is a window of opportunity in that 2 year period to get access to rehabilitation because that need doesn't change no matter what. Get access to understanding the kinds of lifestyle changes that can help the person, getting them access to disability supports, um, starting to think about home care, even starting to think about palliative care, because thinking about that doesn't mean end stage. That means starting to plan and know what you might want and putting those things in place. Power of attorney, getting a legal and medical power of attorney in place. Those are things you want to do during that period of time. And these are things that you can do no matter what. I mean, ideally, you should have the diagnosis in tandem, but those are still supports that can be given prior to the diagnosis.
Hmm. I think it's one of those ones that we've talked to again on the show before. The idea of we have to have these advanced conversations and at least start to be aware of what our family wants. And then when we start to see it, then rather than wait for the system to inform us of, like you said, power of attorney, great example, start having these conversations so that if this thing does happen, this is what um, a great thing is. This is what I want. This is how I want to address it. This is how I want to navigate it in advance rather than waiting for, it to be system imposed.
Well, yeah, and in advance of it becoming a crisis, right? And by the time you've hit a crisis, then usually the only option is long-term care. We know 80% or more of people do not want they want to age at home, or they want to age in a space that is appropriate. Long-term care is usually not the first place that people say they want to go to when they're aging, um, which is great. But then you got to plan. What does that mean financially? What does that mean in terms of the difficult decisions around caregiving and supports? What does that mean in terms of power of attorney? All of those pieces need to be thought about and talked about fairly early. And I have those conversations with my parents. Neither of them are at that stage at all, but I've already started saying, like, let's plan this thing. What does that look like for you? What's important for you? Like, what's purposeful for you? So that when I have to make those decisions, I can make it in an informed way instead of under crisis. When you are making decisions under crisis, you are not making good decisions ever.
Hmm.
You can intake all of the information and process it in a way that is beneficial. So how do we do that so that people can have all of that ready ahead of time?
Well, Saskia, it's time for lightning round. Ready?
I'm ready.
All right. Coffee or tea?
Coffee. Black.
Decaf or calf?
Oh, calf.
I haven't had one decaf person other than me here. um, what do we need first, global or local change?
Local.
What's one policy word you'd happily retire?
There are many. Do I have to pick one?
Give me three.
Action plan. Adequate resourcing. I'll stop there. There's many more, but I think those could be retired.
What's one metric that we use that ultimately ends up misleading us?
I have to think about that. One of the learnings from the UK was diagnosis rate. They tried to make sure they had a certain diagnosis rate, but because they used that metric, they hadn't thought through what happens post-diagnosis. So you had a whole bunch of people who were now diagnosed, but still didn't have the supports they needed after that diagnosis. And that's often been raised with dementia as a problem if we only focus on one thing.
Hmm,
One.
interesting. What do you think is one group that's missing presently at the dementia table?
Well, there are many groups missing at the dementia table. I mean, the Indigenous communities are many communities, and they're not at the table. Not enough, I think, not enough in a presence. A lot of ethnically diverse communities are missing at the table. People who speak different languages, have different ethnic and cultural needs, they're often missing at the table. But really, even people living with dementia, while they are sometimes at the table, I don't think they are empowered well enough to actually push for what they want at that table. Can sometimes feel like a checkbox versus an actual um, engagement.
Interesting. Uh, what is one myth about these national strategies that people have?
That having a strategy means that you're going to be able to get anything done.
I mean, I teach an undergraduate course in strategy, and the dementia strategy, for example, doesn't actually meet the requirements of said strategy, at least from business lens.
Yeah. The strategy is only good as how you can actually articulate and implement your vision. And a national strategy, we've seen many of those. Many provinces have 4 versions of a dementia strategy. Not much has changed.
What is one unintended policy consequence you have seen?
I can't think of like an explicit one, but I do know that often with policy changes, there are downstream system impacts that are not always that policymakers are not always aware of. And that happens when there's a disconnect between the community that's receiving the outcomes of those policies versus the people who are making those policy decisions. And that's why those consultations are so crucial before anything gets implemented.
What is one barrier we're seeing that is impacting the scaling and growth of home care for folks?
Oh, home care is enormously underfunded. It's been cut to beyond the bone at this point. And I know people hate talking about funding and resourcing, but everything we say about aging with dignity, wanting to age at home, coordination of care, supporting caregivers, home care is the backbone to be able to enable that.
What's one funding mistake we keep repeating?
Developing a strategy.
What's one thing people with dementia are often excluded from?
People living with dementia are excluded from a lot of places because people make the assumption with the diagnosis of dementia that they no longer are capable or can valuably contribute to a conversation of any sort, including their own care. They're excluded from their own care, let alone from any other policy, system, programmatic decision making.
Phyllis Fair is a wonderful example of this, even in the people can listen to the episode, but she talks about when she was diagnosed and the doctor was talking to her up until the moment she got diagnosed, then to the husband it goes.
Yeah. I recently had a conversation with a lawyer whose client and his wife has just been diagnosed with dementia, and the lawyer's first question was, "Oh, should I be involving her because they're going to be making decisions about estate planning and their wills?" And I said, "Why do you think that just because she has a diagnosis, she's not able to participate? Like, we don't do that for other conditions. You can assess capacity, and legally, that's important to do, but don't just assume right off the bat because of that diagnosis that that's not possible."
What's one small shift that you think we need to make in our dementia strategies?
That's an unfair question
Make it
because
a big, make it a big shift.
it's a big shift. Um,
I guess
uh,
what's the low hanging fruit? What's the low hanging fruit?
the low hanging fruit is identifying people whose role and responsibility is to coordinate care at the provincial levels. Period.
Is there any place that Canada leads globally in dementia?
Yeah, I mean, I know we talked about a lot of things that Canada's not doing well, but Canada is a country that has really embraced understanding diversity and Indigenous need. Canada is a country, I mean, in dementia specifically, Canada has embraced um, dementia friendly communities. The idea that communities can be open and supportive to people living with dementia. Those are some of the places where it I wouldn't say it's leading, but it is willing to move forward with.
What's the most human thing that's happened to you lately?
I have an 8-year-old who keeps me very human and grounded. I would expect him to barge in here at any point. It's March break right now. But yesterday, we built a makeshift ski slope in our family room and then proceeded to do belly slides down it. And it reminded me, with all the work we do and all the noise around us, that human connection and that joy in the 5 seconds of sliding down, that's that's what connects all of us. That's what grounds me.
What gives you hope?
I do think that ultimately people want what's best for others as much as they want it for themselves. And when I think about dementia specifically, I don't know a single person at this point who is not aware of dementia or knows someone who's been touched by it. Everyone I've talked to, from like the bus driver to anyone that I just meet in a lineup at the store. And I'm hopeful that that means when you have that personal link and experience, that you want something better.
Well, Saskia, I always give the guests one last word in the episode to tell the listeners whatever they want or to have the last say. So, what would you have to say to them today?
I would say that you are a voter. You're a voter first and foremost, and your MPP and your MP is in their position because you voted or because you are in their constituency. And I would not underestimate the power of calling them, reaching out to them, setting up a meeting, and telling them how important this issue is to you, if it is really important to you. I have done that myself as a constituent, and I have been surprised at the number of people who have answered my emails, had meetings, and been willing to push the envelope for me.
I think that is so important. I
Yeah.
would agree with you there. Well, Saskia, thank you so much for joining us. It was a pleasure to talk about policy and system and what Canada needs to do going forward. So I really appreciate your time. So thank you.
Thank you. Thanks for having me and for a great discussion.
Of course, it was our pleasure. And to our listeners, thank you as well for being here. If today's conversation resonated with you, make sure to follow the Dementia Collective wherever you get your podcasts. Don't forget to share this episode with someone who you think might benefit. 1 in 5 folks have a relationship with someone with dementia, so there's lots of folks out there that need to hear this message. And if you'd like to help us grow this movement, please consider becoming a member of the Village on Patreon. Among the benefits, like the ability to ask questions to our guests, you'll get early access to every episode, plus the satisfaction of helping powerful voices like Saskia's reach more caregivers, not just in Canada, but around the world. And finally, if you're on your own caregiving journey, remember, you are not alone. We're here at BlueBell to help connect you with the supports and resources that truly fit your family's unique needs. Until next time, remember, you are strong, you are not alone, and you're doing something that matters more than you know. I'll see you next time.